In lecture 4 here, we're going to talk about both the neural structures and then the vascular structures of the spine. So the spinal cord, the spinal nerves, and then the blood vessels that are associated with the spine itself. All right, so we'll start with the neural structures. The first one, the major one, the spinal cord. It occupies 2/3 of the spinal canal. So if we draw our vertebrae here, we have our pedicles like this. Our lamina come in like this. This is our spinal canal. It occupies 2/3 of this vertebral canal, okay? It's enveloped by the meninges along its entire length, which, to review, is that pia mater, arachnoid, and dura. That's shown right here, those 3 layers. It has gray matter and white matter, just like the brain. If you remember the brain, the gray matter is on the outside in the brain. So this is the gray, and then the white matter is on the inside. Okay, so this is the white. And it's the reverse for the spinal cord. So the gray matter here is in the center, as you can see it here. It's kind of like a butterfly shape to it. This is the central region, and it contains the neuron cell bodies. So a few things to be aware of. So this is your ventral horn. This has motor cell bodies, okay? Motor CBs, we'll call them that. Then you have your lateral horn, which is shown here. Okay. Lateral horn also can be called intermediate horn. Okay, you'll see both terms. Okay, so lateral horn. This is ANS cell bodies. Okay. Now remember, we're going over this again because it's just so important to understand where these cell bodies are. It's very high yield for exams, okay? And it just helps you understand the anatomy better. So, and then lastly, sensory neurons are located both in the dorsal horn. So this is the dorsal horn. Then the dorsal root ganglion, okay? So we have the dorsal root that comes out here, and then you have the dorsal root ganglion that forms before you go into the spinal nerve. And if you remember the dorsal root ganglion, or the DRG, if it's shaped like this, it has a bunch of cell bodies in it, okay? And they can both be somatic and autonomic innervation, okay? And you remember they have the neurons that come out like this, that go both ways, okay? The white matter here is located peripherally and contains neural tracts traveling to and from the brain. So you have some tracts here, here. We won't get into what these tracts are. That's more of a neuroanatomy topic. So next you have the Conus Medullaris, which is the terminal end of the spinal cord. So it's this conical shaped structure here. And if we outline the vertebrae here, so you have L1 here, L2 here, and then you have T12 here. The Conus Medullaris is thought to be located at the T12L1 level, vertebral level, so here. There's some sources that'll say it's at the L2 level. Now again, use whatever your class notes say for your particular exam, but just know that at least clinically, most people are going to consider it at the T12L1 level. Now, the Dural Sac. So you have the dura, which is that outer tough layer coming down all along the spinal cord on all sides. It's a continuation of the dura beyond the Conus Medullaris. So you have your Conus Medullaris here. This dura is a continuation here that continues in the lumbar and sacral spine, okay? And then it continues in here like this, and then terminates down here in the sacral region. And it houses the Cauda Equina, which is shown here. These several terminal spinal nerves of the lumbar and sacral regions, and they'd be traveling in here as well. And it houses those nerves in the sac, and it also has a terminal point via the Filum Terminale, which is a thick ligament here that helps it insert down into the terminal vertebral column. And we'll go through that in a little more detail in a couple slides. All right, so the Cauda Equina, what is it? Like we said, it's a collection of the final lumbar and sacral spinal nerves. It's the L2 through S5 nerves, and they continue on from the Conus Medullaris. So if you look at this diagram here, you have the Conus Medullaris labeled here, and you have these nerves that are coming out, extending out, and traveling in this region here, the Dural Sac, and are bathed in CSF. And they provide both visceral and somatic innervation. So they provide visceral or autonomic, ANS, innervation to the pelvic organs such as the bladder. And then you have somatic, motor, and sensory innervation to the perineum, and then the lower extremity. So your leg, most of your innervation to your legs is provided by the cauda. It originates in the cauda equina. And what we're going to talk about in the clinical pearl section is the Cauda Equina syndrome. It's a very high yield topic. It shows up on board exams, both step 1, step 2, all the time. It's something that you could see on third year shelf exams. And so what's important to note here is people with Cauda Equina syndrome will often have urinary incontinence, and that's because of this visceral innervation to the bladder. And we'll go through the presentation of that in much more detail in the clinical pearls section of the chapter, of this section of the book. The Filum Terminale, which is this long fibrous tissue cord that spans from the apex of the Conus Medullaris. So we have here Conus Medullaris, and then you can see it traveling all along here. So it travels all the way down here. It's even labeled here for you, Filum Terminale. And then it has two sections. It has the internum and externum, and it's there's the part that's in the dural sac and outside the dural sac into the attaching the coccygeal vertebrae. So first the internum, Filum Terminale. It's extension of the pia mater, which is that inner layer hugging on the spinal cord, just inside the arachnoid, which is inside the dura. And it extends down, travels within the dural sac here, so you can see the Cauda Equina here. And then it inserts here into the tip of the dural sac. Okay, so this is the tip of the dural sac. And that's the end of the internum. So this section of the ligament here is the internum, okay? This segment of the ligament is the externum, okay? It extends from the apex, or the tip of the dural sac, and then it inserts into the first segment of the coccyx, also known as, which makes this ligament also known as the coccygeal ligament. A good clinical pearl here is the lumbar puncture. So the lumbar puncture is a diagnostic procedure that's used to collect CSF, and this is something that's very important to know clinically, especially for like a neurology or neurosurgery rotation. It's also important to know for your step 1 exams, step 2 exams, and just in general in clinical practice. You'll also hear something called a lumbar tap. So this is something that's used to diagnose people with meningitis. It's to diseases like that, infections of the brain and spinal cord area. It also gives an idea. You can see blood products in there, so it can give you an idea of hemorrhaging going on in the brain area or in the spinal cord. So it's a very useful procedure to help you get an idea of what is going on with the CSF, which indicates the health of the brain and spinal cord. So what happens is you insert the needle below the L2 vertebral level. So what's important to remember, we'll say this is L2 here, this is L1 here. You want to insert below L2 because you want to be L2 because you want to be safe. When you're sticking a needle in someone's back, you do not want to stick it in the spinal cord. That's going to create a lot of problems, as you can imagine. So you're doing that to avoid the spinal cord injury. And then the needle is advanced into the dural sac, and you're usually pretty safe if you do. They're a little risky here. They're going a little high. So if you go between the L3 and then L5 level, if you go in this region here, because then you're safe. There's no way you're going to hit the spinal cord. Okay, and so what you do is then you stick it in there and you use it to collect the CSF around the Cauda Equina. Good landmark is the iliac crest. So if we have our pelvis like this as a posterior view, like this, and then we have the spine coming in like this. And then we have our vertebrae like this with our disc. And then our here. So if we have L4, L5, and then this will be your sacrum down here. Okay. The iliac crest, it's a good marker of between L4 and L5. And the iliac crest is good because you can easily palpate this on someone. So you palpate this on someone, and then you insert the needle just adjacent to it. And then you know you're at the L4, L5 level, which is right around in here. Very safe. Nowhere near the spinal cord. Now, on class exams and even maybe on a board exam, this is something that can often be asked, especially with a multiple choice question, especially on like a class exam. They'll be like, which of these layers was not pierced, or which of the following layers is pierced? You can see either version of that. So we'll go through it. So first, you're going to go through the skin. So they label that here. Then you're going to go through the superficial fascia, which is just deep to the skin. Then you're going to go through the supraspinous ligament, which is shown here. So this is your supraspinous ligament, and remember the supraspinous ligament travels from attaches from the tips of the spinous process, the supraspinous ligament. Okay. Then you're going to go through the interspinous ligament. So the interspinous ligament is that ligament that travels in between the spinous process. This is deep to the supraspinous. Then the ligamentum flavum. So if we look at a posterior view of this, again, so we have the lamina coming in like this, forming your spinous processes like this. Again, you have the vertebra just inferior, so you have, again, coming in like this, forming that. The ligamentum flavum goes from lamina to lamina, okay? So this is your ligamentum flavum. And it makes sense that you would have to go through this because this is directly posterior to the spinal cord, and then in the region we're inserting in, but just posterior to the dural sac or cauda equina, okay? So you go through the ligamentum flavum, then you're in the epidural space, and the epidural space means you're above the dura, or you're outside the dura. So that would be in this region here. Then you go through that into the dura. Then you go through the arachnoid matter. Now, why do you go through the arachnoid matter? If you remember, CSF, it travels in the subarachnoid space, okay? Subarachnoid, below the arachnoid, okay? So subarachnoid space, and then you collect the CSF there. Epidural anesthesia block, which often is given for pregnant women, and then also in other cases as well. It stops at the epidural space, so it would stop in here, and it would not go through the dura, not through the arachnoid. You're not trying to collect CSF with that. That's an anesthetic procedure. But again, you would want to insert it into the same region because you want to avoid any injury to the spinal cord. Because even though you're not sticking it in through the dura, you don't want to be anywhere near, if there was a mistake made, you don't want to be anywhere near the spinal cord to cause any damage. All right, so spinal nerves. Now, we went over this in the basics of neuroanatomy lectures in chapter 1. We'll just review here. So you have the spinal cord here. You have your dorsal root coming out this way, your ventral root coming out this way, and it forms the spinal nerve, which then travels out and exits the vertebral column via these intervertebral foramen. So we're going to go to the skeleton model here for a second just to take a look at the intervertebral foramen, also known as the neural foramen, because it's where the spinal nerves exit the vertebral column. So we'll take a little zoom in here. So we'll focus on this intervertebral foramen here where this spinal nerve is exiting. Now, anteriorly, what forms the intervertebral foramen is the posterior lateral aspect of the superior vertebrae. So this part right here, posterior lateral aspect. And then also the intervertebral disc, which is shown here and here. And then posteriorly, what forms the border is, as you can see here, is the facet joint here. So here's that superior articular facet and then inferior articular facet forming this facet joint here. So that forms the posterior aspect of the foramen. Now, superiorly, you have the inferior vertebral notch. Now, inferior, when they talk about the vertebral notches, they're talking in relation to the pedicle, which is shown here. So this is the superior vertebrae. This is the pedicle of the superior vertebrae. And this is the inferior vertebral notch. And so that is what's forming the superior aspect. So it can get kind of confusing. So just to review again, the superior aspect of the intervertebral foramen is formed by this inferior vertebral notch of the superior pedicle. Now, inferiorly, just below where this nerve is traveling is, you have the superior vertebral notch, which is this kind of depression shown in here, of the inferior pedicle, or the pedicle of the inferior vertebrae. So these two vertebrae are what form this intervertebral foramen, so you have the inferior part, and then the inferior pedicle, and then the superior notch, or intervertebral notch, is forming that inferior aspect. And as you can see here, this is where the spinal nerves exit. Now, what you can get is called transforaminal stenosis, which is a kind of a clinical application, and you can get arthritis or degenerative disease in this foramen, which then pinches on the nerves and causes radiculopathy and sensory deficits, and can cause problems. And it's often accompanied with spinal stenosis, so narrowing of the vertebral canal. And we'll talk much more about that in the clinical pearls section. All right, so now we're going to dive into the specific anatomy of the cervical and lumbar spinal nerves, particularly where they exit in relation to pedicles, those type of things, where they would be affected by a disc herniation. And this is anatomy that's often difficult for people to understand at first. And I'll be honest, I didn't completely understand this the first time I took the course. It was really after I had tutored it and explained it and had to study it a little more myself, and even after talking to some spine surgeons about it. And it's important to know because it'll help you understand disc herniations much more easily. And I can almost guarantee you on your step 1 exam, you're going to get a disc herniation question. It's also very common to get it on your third-year shelf exams. It's also common on your step 2 exam. So it's just important in clinical practice, both in, if you go into like orthopedics or neurosurgery, or if you go into even primary care. Often people with these disc herniations are first seen by their primary care doctor. PM&R, that specialty as well, they'll see this. So it's very applicable to a lot of different specialties, neurology as well. So we'll start here with this diagram to help you understand it. So this is a posterior view, okay? This is a vertebral body. And it's almost like we cut through into the lamina, okay? And we just have the pedicles shown here by these circles, okay? And then we have the disc, okay? And so we'll draw our spinal cord in like this, traveling in the vertebral canal. So that's our spinal cord. So what do we got to know about these cervical spinal nerves? So they travel above the corresponding vertebra's pedicle, okay? And then they exit through the intervertebral foramen, as we just talked about with the skeleton model. So let's talk about the C5 spinal nerve. So the C5 spinal nerve is going to come off the spinal cord, and it's going to come down here, and it's going to exit above the C5 pedicle, okay? So this is our C5 spinal nerve, C5 pedicle, okay? Let's go through all these. So then you got C6. C6 comes through here. C7 is going to come out like this. One thing to note also is the nature of, it's not exactly 9 degrees, but the nature at the way the spinal nerve comes down off the cord and then turns just above the pedicle. This can be thought of as a 90-degree angle, okay? So the spinal nerve comes down and almost turns at a 90-degree angle to travel above the pedicle. And then again, this C5, as we talked about in the example, it's going to exit in the intervertebral foramen below, between C4 and C5 vertebrae, okay? So C6, C7, and you get the picture. All right, so now let's talk about the cervical disc herniations. So this is a posterior view. We'll draw our spinal cord here, traveling through the vertebral canal. So they compress the spinal nerve corresponding to the lower vertebrae. So a vertebral level, let's first talk about that, okay? A vertebral level would be the C4, C5 level, okay? It's not C4 level. It's not the C. If you're going to say something's at the C4 vertebrae, you would just say it's the C4 vertebrae, okay? Versus this is the C4, C5 vertebral level. What's the next level down? The C5, C6 level, okay? Then you have C6, C7 level, okay? So a level is considered two vertebral bodies with a disc in between them, okay? And when you're referring to the disc, you're referring to the disc at that level, which is between, obviously, the two vertebrae you're talking about, okay? So the disc at the C4, C5 level would be this disc right here, okay? So let's talk about an example here. We got the disc herniation at the C5, C6 level. So that's this level here. We're talking about this disc. So if we draw a disc bulge in like this, okay? So we'll draw a nice big disc bulge. So that's a disc herniation right there. The C6 spinal nerve is coming down like this, and then it's going to travel out like this, okay? So if you see like this, we'll draw it in a little thicker here. It's coming down like this and then traveling out like this. This is going to get affected. It's not going to affect the C5 nerve because the C5 nerve is up here. C5 nerve is just above the pedicle here. It can't affect that. It's not going to affect the C7 nerve because the C7 nerve is all the way down here. It's got to affect this C6 nerve. So an easy way to remember it is, and this is both true in the lumbar as well, is it's always the lower, the nerve always corresponds to the lower vertebral level. So if there's a herniation to the C5, C6 level, it's always going to be the C6 spinal nerve. That's an easy way to remember it. Disc herniation at C6, C7, it's going to be the C7 spinal nerve. Now, an easy way, but it helps you. I hate to memorize things. You know, there's so much memorization in medical school. It's better to just understand some of this stuff because when you're called out on it, when you're rotating and when you have to use this actually clinically, it's often a lot easier to remember it if you actually understand what's going on. So again, to review, you have this C6 spinal nerve. It's coming down, making this 90-degree angle just above this C6 pedicle, okay? And so that's where, if you have a disc herniation at C5, C6, it's going to protrude right onto that C6 nerve, okay? Now, the most common cervical levels for disc herniations are C4, C5, the C5, C6 level, and then the C6, C7 level. Now, the presentation of cervical disc herniations. Now, the cervical nerves, they go on to form the cervical plexus and the brachial plexuses, okay? So these go on, and then the brachial plexus is what goes on to innervate the upper extremity of the arm, okay? So the symptoms often manifest in the upper extremity. They can involve both sensory and motor deficits, and they can also affect chains and reflexes, okay? And so if you look at here, the dermatome map of the upper extremity, so C4 here, C5 here, C6, C8, C7. So disc herniations that affect these spinal nerves will affect, it can potentially cause symptoms in these regions, numbness, tingling, depending on which nerve is affected. Then a term you'll hear is cervical radiculopathy. You also hear lumbar radiculopathy, but here we'll talk about this in this case. It's impingement. What that means is impingement of the cervical roots and or spinal nerves. And then what that results in, so it's a clinical term, and it results in pain or numbness that radiates down the upper extremity. So you'll often hear about, someone has pain in their neck, and then it radiates down all the way down their arm, okay? So to summarize, these patients, they often have neck pain, okay? They can have numbness in their neck or in their arm, usually more so in their arm or their hand, and then they can also have motor weakness, okay? And often that motor weakness is in the hands. They have weak grip. They have trouble maybe picking older person has trouble with their medications in the morning. Very weak finger movements as well. So some special cervical spinal nerves. C1, that spinal nerve, it only carries motor fibers, so no sensory going on with that. C2, this is more high yield, greater occipital nerve. This is something that anatomy professors love to tag on a practical, okay? So if you're doing a cadaver-based course, make sure you find this, or if you have a pro section in the lab, make sure you find this because you do not want to have any surprises. I'll give you a tip here with practicals. A lot of it is just seeing it, because it's so, there's no labels in the body. So a lot of it is just, I would encourage you to the way you do well on an anatomy practical is you got to just put the hours in. I know it sucks because you've got so much time in lecture and studying and all that stuff, but you got to get in the lab and you got to go through these structures with a friend and go through them over and over again so that you have your landmarks down and your spatial relationships. So that's my biggest tip is with doing well on lab practicals, if you have to take those, is just getting in the reps for the structures, okay? Because it's just the more times you see it, the more you're going to recognize it, okay? And it make you less nervous on test day. So let's talk about this C2 spinal nerve. Gives rise to the greater occipital nerve, and then it pierces. So we'll show that here. So here's your greater occipital, okay? And you can see it kind of coming off here and wrapping up around, and then it pierces that trapezius muscle and comes in through here, okay? So it pierces the trapezius muscle, and it provides cutaneous innervation to the posterior part of the scalp, so this whole region here. And that makes sense. It's traveling in this region. It's going to provide that cutaneous innervation. All right, and just lastly to finish this off, we want to talk about the C8 spinal nerve. So this is something I would get asked a lot. So by students when I would tutor is, so you go down like this with the spinal cord. So let's just review here, okay? Let's take this as a good opportunity to review. So we have the C5 coming out like this at the C4, C5 level. Then you have the C6 nerve coming out like this, okay? Then you have the C7 coming out like this. Now, what does this C8 do, okay? C8 exits below the pedicle of the C7 vertebrae. So the C8 comes out like that. And then this is where that transition happens. So below this cervical level, all the spinal nerves will go below the pedicle. So in the thoracic and then the lumbar region. Some special reflexes to note for is the C5 spinal nerve is tested by the biceps brachii. So if you have a disc herniation at C5, it may ask if you have a test question that may ask what reflex is diminished or weak, would be the biceps brachii reflex. Brachioradialis reflex is for C6, and then the triceps brachii reflex is for the C7. Okay, and this is very frequent. I would write this down or make a note of this. This is very high yield for test questions. It'll give a classic board exam would give you an example of let's say a disc herniation at C4, C5, which is going to then compress your C5 nerve. Okay, that's going to give you a weak biceps brachii muscle. And so what it'll ask you is, it'll give you a presentation of this, and somehow you'll have to figure out that it's the C5 nerve. Then and then the test question would be, which of the following reflexes is diminished? And you can't, if it's C5, brachioradialis is wrong, triceps brachii is wrong. You got to hit biceps brachii. All right, so now the lumbar spinal nerves. So we have this same diagram here. We have a separate one in your book, so you can draw in what I'm going to draw here for the lumbar as well, in addition to your cervical diagram. So one thing to note here is, if you remember, the spinal cord ends at about T12 to L1. So there's no spinal cord traveling in here. What is traveling in here? It's the cauda equina. So we want to talk about the spinal nerves of the cauda equina, okay? So what's important to know in the lumbar is they travel below the corresponding vertebra's pedicle, okay? So let's talk about L2 here. So L2 will come in, and it doesn't do that 90 degree. It goes in an oblique angle below the pedicle. So that's L2. You have L3 that comes in like this. L4 comes out like that. L5 like this. And then S1 like that, okay? And they kind of go at this oblique angle. It's almost like you're draping them down, and they go just below the pedicle corresponding to the vertebra, okay? So our example is, we have in our text here is we have L4 spinal nerve. It travels below the L4 pedicle, and then it exits through the intervertebral foramen between L4 and L5. So now let's talk about lumbar disc herniations. They compress, again, the spinal nerve corresponding to the lower vertebra. So the way you can easily remember this, easily memorize this, is that at a vertebral level, so we have our L2, L3 level, that's going to what? What's that going to compress? The L3 nerve. You have L3, L4, that's going to compress the L4 nerve. The most common ones are these, is L4, L5, and then L5S1. These are the two most common lumbar disc herniation levels, okay? So let's talk about L4, L5. So we have the L5 spinal nerve, which is coming down like this. It's going to drape out like this. And then the L4 nerve comes out like that. So that's L4, that's L5, okay? So if we have a disc herniation here at the L4, L5 level, it's going to be right in here, okay? Now, as you can see here, the L4 spinal nerve has already exited. It's tightly going below this L4 pedicle. So it's safe. It's not going to get affected. It's going to affect this L5 spinal nerve, which is still traveling in the vertebral canal. It's in that dural sac, right, that we were talking about a few slides ago. So the L5 spinal nerve is traveling down here, and it's going to get nailed by this disc herniation, which is going to give someone a lot of pain and a lot of problems. And so this L5 is going to come down and then travel out below the L5 pedicle. So that's how you know. So L4, L5 vertebral level, it's going to compress the L5 spinal nerve. Now, the symptoms of lumbar disc herniations, they manifest in the buttocks and the lower extremity. So what happens is this is low back pain. Okay. One of the most, if not the most common complaint at a doctor's office. So it's going to start in the low back pain, and then it's going to radiate down into the buttocks or even into the lower extremity, and it can go down all the way to the foot. So it can involve sensory and motor deficits. It also can involve changes in reflexes. So what do we look at here? We got our lumbar and our sacral plexuses. These nerves, they come off these plexuses in the pelvis region, and then they go in and form nerves that go on, specifically the sciatic nerve, which then goes on to innervate the lower extremity. And you may have heard of the term sciatica, which is that low back pain that radiates down the buttocks and all the way down the leg, often to the knee or even beyond. That's a result of the nerve roots of the sciatic nerve getting compressed by a disc herniation, okay? Now, again, we talked about cervical radiculopathy. Let's talk about lumbar radiculopathy. This is a clinical term It's used, what it specifically means is you have impingement of the lumbar roots and or spinal nerves that result in pain and numbness that radiate down the lower extremity, hence the term sciatica. All right, so we'll close this out by talking about these lumbar spinal nerve reflexes. Just like the cervical one, these are very high yield to know. They're important for both your board exam and your class exams. They indicate the patellar tendon reflex is indicative of the L4 spinal nerve. So if the L4 spinal nerve is impinged, you're going to have a diminished patellar tendon reflex. If your S1 spinal nerve is impinged, or spinal root, you're going to have your Achilles tendon reflexes diminished. So again, a classic board exam question would be, so you have a disc herniation at L5 S1 vertebral level. That's going to compress the S1 spinal nerve. Okay. And then what the question will ask you is, which of the following reflexes is diminished? And so what would happen is you would have decreased S1, or a decreased Achilles tendon reflex. All right, just to close these neural structures out, we got the sympathetic chain. We talked a little bit about this in the basics of neuroanatomy in chapter 1, just to talk about it, how it relates to the spine. So it's a pair of trunk structures. So they travel on both lateral surfaces of the vertebral bodies. So you can see it in the diagram here. It's traveling down this lateral surface. There's another one here that would travel down this lateral surface. You can actually see this in your cadaver. If you dissect down to the vertebral bodies, you'll see these beaded-like structures. It begins in the thorax at the T1 vertebra level, and then it descends down the vertebral column. Both trunks in the sacral region, so at the terminal region here. So you have this, if we have an anterior view of the sacrum like this, okay? So the sacrum's kind of this triangular diamond shape, or triangular shaped bone. So if we have the sacrum here, we have our sympathetic trunks coming in like this. They course medially in this region like this, and then they converge on this ganglion of impar, which is right here, which is the terminal structure. And that's not terribly high yield for a board exam, but it could be on an anatomy exam. They could ask you where a sympathetic chain terminates. And so they converge onto this ganglion impar, and that's anterior to the coccyx. Okay? Now, with the sympathetic chain, we went through this in much more detail in the basics of autonomic nervous system. It's a passageway and synapse point for sympathetic fibers. The left sympathetic trunk, which is important to know, is just lateral to the thoracic and abdominal aorta, and you can see that here. So here's the aorta traveling here on the front of the vertebral column. In this case, the aorta is just medial to the sympathetic trunk. All right, and so that wraps up our discussion of the neural structures relevant to the spine. So now we'll talk about the blood vessels relevant to the spine. First, we're going to talk about the aorta. It comes out of the heart and forms the aortic arch, as you can see here. Then after the arch, it descends along the anterior surface directly on top of the vertebrae in the thoracic and abdomen regions. This puts it at risk during discectomy spine surgery procedures. So if we look at our disc here in between our two vertebral bodies, just like this. This is anterior. This is posterior. Here's our aorta traveling down on the anterior surface, so our aorta. And then here's our disc that bulges out like this. And a discectomy is a procedure you stick a long surgical instrument in, and you basically are grabbing the disc fragments that have protruded out. Now the problem is, what you're at risk for is if you go too deep into the disc space, you can injure the aorta. If you grab part of the aorta, that's not a good thing. So that's something to be aware of during these procedures. Now, it bifurcates, the aorta bifurcates into the common iliac arteries at the L4 vertebral level. So you can see this bifurcation here. This is the L4 vertebra in the abdomen. Now, this is a very important fact to know. This is something you just got to memorize. You got to know it. This is something that could show up on an anatomy exam, a board exam. It's just important to know. You could get pimped in the operating room during your surgery rotations during your third year. So it's just important to know. And then the IVC, or the inferior vena cava, that bifurcates at the L5 level. So that's important to know too. Vertebral artery. So it arises from the subclavian artery, which is an artery that comes directly off the aortic arch. So if we have the heart like this, and then you have the aortic arch like this, okay, and then you have the three arteries that come off like this. You have on the left side, you have the subclavian artery that comes off. On the right, you have the brachiocephalic artery, which then breaks into the common carotid and then the subclavian. So you have the subclavian here, subclavian here. This is where the vertebral arteries come off of. And you can see that here, actually. Here's a good structure. Here's the subclavian artery. Here's your common carotid, which goes up and supplies the brain. Here's the subclavian that comes off here. This is a beautiful picture of your vertebral artery coming off the subclavian and then really the whole course. Beautiful picture. It enters the transverse processes of the cervical vertebrae, so it travels through those transverse foramen. Very important fact to know, C6 vertebral level, so it does not go through the C7 level. The vertebral artery does not travel through the C7 transverse foramen. So you can see it here traveling in the foramen here and going up through, ascending up through the cervical vertebrae. And it goes through each cervical vertebrae and then exits at the C1 vertebral level. So you can see that here. Then it forms like a nice loop-like structure here, travels across the arch, the posterior arch of C1. So remember those arches, there's an anterior arch, posterior arch of C1, and then travels through the suboccipital triangle, which is this region just below the occipital bone, and then through the foramen magnum, which is this structure here, which is it's the opening in the inferior portion of the skull that allows the spinal cord to exit from the brain and enter the spinal column. So it ends, and then it travels through that foramen magnum into the skull. Within the skull, the two vertebral arteries, so you can see it here, both here. So the vertebral arteries, they kind of come up like this, and then they form a artery called the basilar artery, okay? So this is one vertebral artery, this is the other vertebral artery, and then they converge here within the skull. And the basilar artery is just the main blood supply to the brainstem. We will not go into any more detail than that because that is a neuroanatomy thing, but just so you're aware of it. Something a good clinical tie-in here is, you may have even heard of these stories on the news, is if you have like excessive manipulation to the neck, to the cervical spine, it actually can create an embolism in these vertebral arteries. And then because what you're doing is you're manipulating this spine, and since this artery travels within so close to these vertebra, they can get damaged and cause emboli to form in them, and then the emboli travels up through the vertebral artery and all the way up into the brain. It can result in a stroke, and some people have even died as a result of this. So it's very, very serious. The other thing to be noted of is also in trauma. Another example is in surgery. So if you're operating on the cervical vertebrae, the vertebral artery is something you want to be very aware of because you do not want to damage it. We'll just go through these briefly. There's two vertebral venous plexuses that help form the venous drainage of the spine. The internal one is located in the epidural space, so you can see that here. Here's your spinal cord, and then here's your internal vertebral venous plexus. It forms an anterior and a posterior network. So here's your anterior network. Here's your posterior network. Okay. And then it communicates superiorly with the cranial dural sinuses. These are sinuses that are in the brain that help drain the brain, and so that's a good thing to be aware of. We'll go into more detail about that in the head and neck, and that's also a neuroanatomy topic as well. Then the inferior portion, it communicates with the prostatic venous plexus. And this is believed to be a conduit for prostate carcinoma to metastasize to the spine. So one of the most common metastasis sites for prostate cancer is bone, and specifically the vertebral column. That's often a sign of advanced prostate cancers if it's metastasized to someone's spine. And often on a test question, you'll get asked about a prostate spinal met. You'll have something like that. I was talking about that Cauda Equina syndrome or spinal cord compression. And what it is, in fact, is that it's a gentleman that has prostate cancer that's metastasized, unfortunately. External vertebral venous plexus, just to finish this out, it forms an anterior part that travels anterior to the vertebral column. So this is a great picture here. It's like we took the vertebral column and turned it this way. So this is anterior down here. You can see your spinous processes here, and then here's your posterior region. Then you have the external part of it, the posterior external plexus. So you have an anterior external plexus, posterior external plexus, and that travel near the vertebrae. And then they form an anastomosis with the vertebral venous plexus on the inside, the internal vertebral plexus. So you have the anterior and posterior external plexuses traveling out here, and then you have the interior in here, and they form these nice communications with each other. So it's a big venous network that helps drain the spine. And that closes out our discussion of the neural structures and the blood vessels relevant in the spine.